So this is the case to see or not to see a case of multiple cranial nerve palsies. So there's numerous neurological complications that have been described in association with influenza infections. But few case reports have described relationships between influenza and cranial nerve palsies, and those that have primarily done so with influenza B infection and singular cranial nerve palsies. Here we describe a case of multiple cranial nerve palsies associated with an influenza A virus infection. So a 46-year-old healthy male presented to the hospital with acute binocular diplopia and drooping of his right eyelid. He stated that the visual symptoms started suddenly a few hours prior to the presentation to the emergency room and came on sudden onset when he woke up. He also reported a 2-day history of malaise, cough, pyrexia, night sweats, and myalgias. His exam demonstrated persistent bilateral binocular diplopia that was worse during leftward gaze. He had a partial right cranial nerve 3 nerve palsy manifesting as right-sided ptosis. He had a left cranial nerve 6 palsy manifesting as reduced left eye abduction. And he had a partial cranial nerve 5 palsy with reduced sensation in the V3 distribution bilaterally. His pupils were equal and reactive, and the rest of his neurologic and systemic exam were normal. Infectious symptoms were consistent with a viral illness, and an NP swab confirmed influenza A infection. CVC showed lymphopenia, and serum electrolytes and creatinine were normal. His CTA head and neck was negative for a stroke or mass lesion, and the manifestation of multiple cranial nerve palsies was suspicious for leptomeningeal disease with brainstem lesions, CNS infection, inflammation, or malignancy. MRI brain with GAD demonstrated no brainstem or leptomeningeal enhancement, but there was a small linear T2 hyperintense enhancing lesion inferior to the right optic nerve, and this is demonstrated in figure 1A, and an unchanged right retropharyngeal lesion demonstrated in figure 1C that had been present since 2015, 3 years prior. CSF assessment showed elevated protein and mild lymphocytosis. CSF was negative for gram stain, culture, AFB, fungal cultures, HSV1 and 2, EBV, CMV, and HZV. CSF flow cytometry showed no definitive immunophenotypic support for lymphoproliferative disorder. His CT chest was normal. A 5-day course of oseltamivir for influenza A infection resulted in complete resolution of the cranial nerve palsies with significant improvement in his diplopia. Ophthalmology suggested that the optic nerve findings on CTA were either incidental or an inflammatory response without any optic neuropathy, and they suggested follow-up brain imaging in 2 to 3 months. He has had follow-up brain at 6 and 12 months post that have all been normal. ENT assessment was also normal. In the absence of other etiologies, it was hypothesized that the influenza A infection contributed to this patient's neurologic findings. At 6 weeks follow-up, his diplopia and ptosis had completely resolved. Cranial nerve exam was completely normal. Autoimmune workup, including ENA profile, had returned negative, and serum IgG4 levels were also normal. So in summary, although rare, viral respiratory infections can cause neurologic findings such as cranial nerve palsies exhibited here. And this report describes a case of multiple cranial nerve palsies secondary to an influenza infection. Thank you.